Welcome to Debates of the Century. Please take your seats and silence your cell phone. The program is about to begin.
Good evening, everyone. I'm Sherry Gleed, and I'm the Dean of NYU Wagner's Graduate School of Public Service. It is my honor and my pleasure to welcome you to tonight's debate. About 3 years ago, Mark Zuckerman at the Century Foundation and I had a conversation and thought it would be wonderful to start a debate series here in New York that would offer thoughtful, informed dialogue from diverse experts on issues of vital national importance. And we went ahead and did it. We've had 8 debates so far, including on education, national security, immigration, policing, and gentrification. And we're thrilled to continue in this enterprise. Here at NYU Wagner, we have a long history of engaging with issues of significance to public service. For over 75 years, we've been helping our students translate their passions into action so that they can take make an effective and lasting impact on the public good here in New York City and around the globe. Our alumni, who are all over the place, they make a real impact every day in healthcare, in international development, in urban planning, in nonprofit management, in finance, and many other fields. One of the ingredients that goes into making such a substantial impact is really understanding the multiple perspectives that come with an issue. And the conversation tonight is an example of learning about those perspectives. Tonight's discussion is going to focus on Medicaid and ask the question of whether able-bodied people should be required to work in order to receive their health care benefits. I'm pleased to welcome our debaters as they present their arguments on both sides of this challenging topic. We may not agree on what the right outcome is, but I think we do all agree that this kind of dialogue is really important. I want to welcome our moderator, Aaron Phillips, and our debaters, John McCarthy and Vicky Wakina. Where are they? They're coming. I'm welcoming them. Come on in. I welcomed them too fast. Welcome. They're going to receive proper introductions in a minute. But first, on behalf of NYU Wagner and the Century Foundation, we are very grateful to them for being a part of our debate. We are live streaming this debate to an audience outside of this room here in the Puck Building, and we want to welcome those online. In addition, when we began these debates, Mark and I agreed that it would be great to have audience participation, that would be a key part of the debate experience, and so we're going to be hearing from you, the audience. There are 2 ways that you can take part in tonight's conversation and ask questions. First, on Twitter, for those of you who like to tweet, and also by old-fashioned index cards, which are being handed out. So for Twitter, submit a question using the hashtag DOTC, which you will see in your programs and on the screens. And the second way to ask a question is just to write it on an index card. Simply raise your hand at any time during the debate, and an usher will give you an index card and pick it up from you. They also have extra index cards if you didn't pick any up on your way in. So before we start, we want to take your pulse about today's topic. We're going to conduct a poll right now, and then again after the debate is over to see if people's opinions have shifted. So you can join our poll in one of 2 ways. You can join us via text. Simply text DOTC to 37607. Or, especially for those of you on the live stream, you can go to your web browser, go to pollev.com/DOTC and follow the prompts. There is no need to register or log in. No one needs to know who you are. I will give you all a second to join the poll through text or your browser. Instructions are on the screen. Are you all ready? Looks like people are ready. Okay, let's poll. Tonight's resolution is people who can should be required to work for their Medicaid. Do you agree or disagree with this statement? After you've joined the poll, simply text yes, no, or undecided. Okay, let's see the results. They're coming in. Those of you who took statistics remember that when the numbers are really small, the results are very variable. We will do another poll after the debate to see if our experts were able to sway any opinions. But it is now my pleasure to turn the stage over to our partner in this endeavor, the Century Foundation. And tonight we have a special member of the foundation talking with us, and that is our senior fellow and my good friend, Jean Lambert.
Good evening. Thank you very much, Sherry. As Sherry said, I'm Jean Lambert. I'm a senior fellow at the Century Foundation. The Century Foundation is a progressive, nonpartisan think tank that seeks to foster opportunity, reduce inequality, and promote security at home and abroad. Debate, by definition, involves differences. Some of us come in with points of view, including myself, having worked in both the Clinton and Obama White Houses on Medicaid. But tonight, hopefully, we're going to come in with open minds, because significant and durable public policy rests on questioning assumptions, examining evidence, and being open to change. We have excellent speakers tonight who will hopefully help you do so. So before introducing Aaron, who's going to moderate our debate, I'd like to provide some brief context for those of you who are not expert on healthcare policy. We're going to talk about Medicaid. Medicaid is a health program created in 1965, primarily at that point for low-income people with disabilities, seniors, and mothers with children with very low income. Since that time, the program has expanded to cover all poor children, all poor seniors, more people with disabilities, etc. But it took until the Affordable Care Act in 2010 to try to get Medicaid to be a safety net for all low-income people. So the Affordable Care Act would have expanded, or did expand, Medicaid to 138% of the federal poverty level. Translating that, that's about $17,000 in annual income for a single person. But because of a Supreme Court decision in 2012, it's not a uniform nationwide floor. Instead, it's a state option. Since that time, 32 states plus the District of Columbia, including New York, have taken the option to expand Medicaid. We know currently the state of Virginia is debating whether or not it will expand Medicaid. The state of Maine last fall passed a ballot initiative. It will be expanding expanding Medicaid this summer, barring any obstruction from the governor. And it's interesting to note that for those states that have not taken this Medicaid expansion, the median upper income eligibility level is 43% of the poverty level. 18 of the states that have not yet expanded Medicaid don't actually provide an option for childless adults. That standard is just for parents. So a number of states that have actually expanded Medicaid have sought to do so simultaneously with reforms to the program, often through demonstrations called waivers. Section 1115 of the Social Security Act gives the Secretary of Health and Human Services authority to approve experimental, pilot, or demonstration projects that promote the objectives of the Medicaid program. We'll be hearing a lot about that in this debate. In so doing, states can waive certain legal limits of Medicaid to test whether or not these demonstrations have this promote the objectives of the program. Last January, the Trump administration issued guidance on these waivers, encouraging states to apply for Medicaid work requirement demonstrations. The administration subsequently approved 3 such demonstrations, and 8 additional states have applications pending. Additionally, beyond Medicaid, we've learned from the Trump administration just 2 days ago that the administration would like to consider work requirements for other programs, such as low-income housing, food stamps. So the executive order the president issued asked a whole bunch of agencies to come back in 90 days with additional recommendations of can you extend work requirements beyond the Medicaid program. As you'll hear shortly, and hopefully throughout this debate, this idea is something that should be debated. So to moderate this discussion, I am pleased to introduce Erin Phillips. Erin is NY1's health reporter, a post that she's held for 5 years. She also hosted NY1's weekly health program, City Health Beat, for 2 years. Before that, she was the first reporter stationed at Time Warner Cable's Washington, D.C. bureau, covering, among other events, that Supreme Court decision that I just talked about that made Medicaid an option rather than a mandate. She also has previously covered New York State policy and politics from Albany, and I'm positive she will help lead us into a very good discussion. So let's welcome Aaron to the stage.
Thank you, Jen. So tonight's discussion is a classic example of the ideological differences between the right and the left. It's an argument that has little legs in a state like New York, a liberal stronghold, but for many other states, the conversation around who should receive access to Medicaid is a real and in some cases life or death conversation. As a reporter, it is easy to get lost in the statistics, the big picture, the philosophical rights and wrongs of America's approach to healthcare, which is why many of us journalists take pains to boil the problems down through the lens of a person, the patient's story. So many lives have been turned upside down because of a lack of access or barriers to care, from those with complex medical issues to those who simply need preventative advice from a primary care provider. Conversely, the stories of medical triumph due to someone who was once without care finally gaining access and good health is what motivates us all to have discussions like the one that is about to start. So we hope you keep the people most impacted in mind as we wade through this complex, important issue, and perhaps you, our audience, will walk away with a greater understanding of both viewpoints and a firmer personal position on whether people who can, should, work for access to taxpayer-funded healthcare. So after I introduce our speakers, each will have 5 minutes of opening remarks, and then each will get to do a 3-minute rebuttal. And then the debate will start and go on for about 30 minutes, after which we will open up the floor, the conversation to the audience for about 20 minutes of questions. Many of these questions have been pre-submitted, but we welcome you to continue to send in questions via Twitter, and we'll keep that hashtag on the screen there. It's hashtag DOTC, and we'll also have people with index cards around the room, so you can, if you are seated here, you can fill in your own index cards. The speakers will then be allowed to offer timed closing segments of 3 minutes each, after which we'll invite you all to vote on the winning argument of the debate one more time. So with that, let's meet our speakers. John McCarthy is a senior strategic advisor at Sellers Dorsey, providing guidance to the firm and select client engagements on Medicaid health policy and managed care programs. He directed the state of Ohio's Medicaid program, and before that served as Medicaid director for the District of Columbia. He also served as vice president of the board of directors for the National Association of Medicaid Directors from 2015 to 2016. Please join me in welcoming John McCarthy to his podium. Vicki Wicino is currently the principal of Viaduct Consulting, a boutique consulting firm advising organizations serving individuals with complex health and social needs. Before that, she served as deputy administrator and director of the Center for Medicaid and CHIP Services at the Center for Medicare and Medicaid Services from 2015 to 2017. She has also served in leadership roles at the Kaiser Commission on Medicaid and the Uninsured, the Center on Budget and Policy Priorities, and the U.S. Office of Management and Budget. Please welcome me and join me in welcoming Vicki Wicino. And with that, John, you have the floor for your opening statement, 5 minutes.
So first, thank you for having me. This is great that you're having this debate, and so hopefully we'll have some good dialogue. And obviously the numbers were kind of against me there, so I have a lot of work to do today. So what are we debating today? Is it making children and disabled people work in order to stay on Medicaid? No, we are not. CMS has been clear that work requirements do not apply to those populations. The people who are included are the non-disabled working-age adults with incomes below 138% of the federal poverty level. Not children, not the elderly, not the disabled, and not pregnant women. The real issue we are talking about today is the role of the Medicaid program in the social safety net. This is really a debate around the value to the person and the community employment or community engagement brings. A topic that we have heard a lot about is the social determinants of health. The 5 key areas include neighborhood and built environments, health and healthcare, education, social and community context, and economic stability. The 1115 waivers that have been proposed or approved for community engagement specifically address 1 or 2 of these determinants. So is helping someone with social determinants being debated? When we expanded the Medicaid program in Ohio, we asked CMS informally if we could implement a link between work readiness, and eligibility. The answer at that time was no. Since that time, the federal landscape changed, as did many states. With the changes in administration, many states are approaching CMS again. The first state to formally ask through an 1115 waiver was Kentucky. What is important to understand about Kentucky is that the new governor ran on eliminating the Medicaid expansion. The Kentucky legislature also was not a supporter of the expansion. So for all practical purposes, Medicaid expansion in Kentucky was going to be eliminated. However, before the governor made that proposal in his first budget, he had his staff reach out to other states to talk through various ideas. Ohio was one of those states. We shared with them what CMS under the Obama administration would and would not allow under 1115 waiver. We discussed at length the Healthy Indiana program that created health savings accounts for people and a similar waiver that I was required by the Ohio legislature to submit to CMS. What they were looking for was a way to keep expansion in a state where the elected leadership did not support it. What they were looking for is a policy that reflected their social expectations, which is, if you can contribute to society, you should. There are about 350,000 people enrolled through expansion in Kentucky. Of those, about half, or 175,000, already have jobs or in other activities that would satisfy this requirement. So that leaves about 175,000 people who would need some type of community engagement. Currently, there are about 200,000 open jobs in Kentucky. To help people get connected to those jobs, Kentucky is spending state-only dollars to improve that infrastructure for work programs so that people can receive training and be prepared for one of those jobs. These new programs Kentucky is putting in place link directly back to 4 of the social determinants: health and healthcare, education, social and community context, and economic stability. Are we debating work and community engagement, or are we debating what is fair? States all have their different ideas of what is fair. We talked to you earlier, this was said. For example, states currently cover parents up to different federal poverty levels. I don't know if you all know that, but it's different in every state. In DC, where I was Medicaid director, we covered parents up to 200% of the federal poverty level. In Ohio, where I was Medicaid director last, we covered parents up to 90% of the federal poverty level. So there was already a difference in there, what was considered fair. These differences are allowed, and each state gets to decide. Looking at what is being proposed across the states reflects this also. The Ohio proposal that they have put forward in an 1115 waiver gives the following exemptions from the community engagement requirements: people 50 years of age or older, people physically or mentally unfit for employment, people participating in the Specialized Recovery Services Program, people caring for a disabled or incapacitated household member, pregnant women, a parent or caretaker residing in the same house with a minor, people who have applied for or receiving unemployment compensation, people in school at least half the time, people participating in drug or alcohol treatment, an assistance group member subject to and complying with any work requirement under the Ohio Works First program, or an applicant or a recipient of supplemental Social Security income. There are close to 3 million people enrolled in the Medicaid program in Ohio now, and nearly 700,000 people in the expansion group. After these exemptions that I just talked about, taking into account nearly half of the people already working, the state estimates that about 36,000 people will have to work and or participate in a community engagement activity for a minimum of 80 hours a month. That is 1.2% of the Medicaid enrollment in the state of Ohio. Ohio defines community engagement activities as SNAP education and training activities, job search, job readiness programs, and work experience programs. In Ohio, the goal of expansion was to get people back to work and off of Medicaid. As of yesterday, there were 177,156 open jobs in the Ohio Means Jobs website. The waiver Ohio is asking for would apply to about 36,000 people. What the state is trying to do is match people to those open jobs. Do we not agree that those 36,000 people would be better off if they had one of those jobs? Thank you.
Century Foundation for hosting this discussion, and to you all for taking part of your evenings to understand the importance and the complexity of this issue. I also want to thank John. He was a very strong and capable leader in 2 different states, as you've heard. He also helped me just today by helping me find the printer in the hotel, and if that hadn't happened, I wouldn't be here. But I will say, I think it's a privilege to have such a strong and capable leader with whom to respectfully disagree. Medicaid makes it possible for millions of low-income children and families to get and stay healthy. It helps them see a doctor when they're sick. It helps them get checkups. It helps them go to the hospital when they need it. And they do it without fear of having to choose between health care and buying groceries or paying their rent. And this is what helps them work, and this is what helps them take care of their families. And if you look at the research, it is clear that having Medicaid coverage improves someone's life prospects. It helps them go to school, it helps them go to college, and it helps them be employed. The policy at issue here is whether states should be able to take away that coverage from someone who doesn't meet state-set arbitrary requirements around work and work hours. That is the question at stake. Not whether they should work, but whether states should be able to take away coverage. This policy is backwards. Medicaid helps people stay healthy, and it helps people work. It is not the tool to inflict a harsh punishment when someone doesn't. The policy creates a bureaucratic tangle of red tape, forms and reporting and documentation that creates paperwork hurdles for people in very difficult life circumstances to have to try to overcome. This is not just ending Medicaid coverage for someone who fails to meet an arbitrary work target. It is ending Medicaid coverage for someone who may very well be working, as most Medicaid beneficiaries do. But if they don't fill out the paperwork properly, or they don't return it on time, they are at significant risk of losing coverage. Many people in this population have serious health conditions, and others, as I said earlier, work. I'd like to give you one example of a person for whom this could be counterproductive. As Erin noted, it's important to have an image of mind of someone who is actually going to be subject to this policy. There is a 56-year-old woman who lives in Louisville, Kentucky. She went to community college but was not able to complete it because she needed to work to support herself. She has worked since then. In her most recent job, she was a custodian. She worked cleaning offices, and part of her job was carrying large containers. In the process of doing that, she hurt herself. She injured her back, or her shoulder, excuse me. She requested an accommodation, and then she lost her job. Currently, her income is $7,800 a year. That represents her unemployment benefits. She's been trying to find a job without luck. She has no car. That makes things difficult. Transportation barriers are not uncommon in the low-income population. She has arthritis, high blood pressure, high cholesterol, chronic chest congestion, and leg, foot, and back pain. She does not meet Medicaid's parameters for someone who is disabled. She is in the expansion population, and she has very serious health conditions. And if she is not able to find a job and meet these new requirements, or if she does so and isn't able to fill out her paperwork, she will lose coverage, and she will not be able to manage those conditions and keep her job. At the same time, the new bureaucracy that's being created to implement these requirements will actually increase costs. It is expensive to actually monitor and implement these new requirements. Yet, despite asking taxpayers to spend more, this policy is very unlikely to succeed as its stated goal. We know from research and other programs that punitive policies like these do not actually increase economic mobility. So in sum, this policy is harsh, it creates costly red tape, and it is likely to be ineffective. It is a policy that is out of touch with the reality of low-wage workers and working families in America.
Vicki, thank you. John, you have 3 minutes for a rebuttal.
So Vicki hit on a case That's a real life case. What we have to remember is this. I don't know what state she was talking about, but that state, in that state, they may make the decision to just completely eliminate the expansion population altogether. You're thinking, oh, that could never happen. I was a Medicaid director in Ohio, right? We expanded Medicaid. Did you know that the Ohio legislature, in the last budget that just passed, was right after I left, they eliminated the expansion once again. Every chance they had, they eliminated it. The governor line item vetoed it. So that's why Ohio still has the expansion. The legislature also put in there that the Medicaid director has to submit a waiver for community engagement. That was the deal, the political deal that was put together. So as I was saying before, there is a debate that's bigger than just should a person have any requirements around community engagement. There's also the issue of, will you even have expansion or not? So the person that Vicki was talking about, there's a chance that there would be no coverage for that person whatsoever. So if you let a state be able to do this, and they have this option of doing it, they keep expansion. And then along with that, if you read the letter that CMS put out, Brian Neal signed it, it specifically talks about those cases. And looking at cases and saying states need to make decisions around how many hours should a person really have to work? What is it? Are there accommodations that are needed to help that person? And on top of all that, nearly all states are also proposing that it doesn't have to be work. It's community engagement. It's some type of volunteering. How can you be a part of your community and making your community better? There's a whole bunch of nonprofits that I worked with in the state of Ohio who had many programs looking for people to help them. Some of the things that were discussed is, how can you get a person into a school to help read to kids? Would that count? Yes, it would count. Those different things would be something that a person could be using and working with a community to make it overall better.
Thank you, John. Vicki, you have 3 minutes for a rebuttal.
This is not just a policy debate about Medicaid expansion. Mississippi has never expanded Medicaid. They have a waiver before CMS right now that would impose work requirements on parents who make as little or less than $5,600 a year. That is the income threshold for parents in Mississippi. 91% of those parents are women. More than 70% of them are African American. If those go through, then those parents are going to be placed in the following position. They can work and increase their income and lose their Medicaid coverage, or they cannot work and lose their Medicaid coverage. These are impossible choices that we're putting parents and families in. And although John is correct that these policies do not directly apply to children, they will have an impact on children. The research is clear. When parents lose coverage, their children lose coverage too. And that is not just in Mississippi. That is in all states. When kids lose coverage, they do not have what they need to be healthy and stay in school. When parents lose coverage, their ability to provide for their families is compromised. That is why this policy is on the wrong track. John mentioned social determinants before, and I want to be clear. There is no one who is saying there aren't complex social problems facing low-income people in America, including employment. But this particular policy of taking away health coverage from someone if they're not meeting arbitrary standards is the wrong track, and we can do better as a country.
Okay, so I'll present the first question for the argument. John, with 2/3 of Medicaid spending for individuals with disabilities and seniors, would a work requirement for able-bodied recipients offer significant cost savings to taxpayers? Many say that the amount of people that would actually be eligible for this mandate is quite small.
The question that you raise is, are we looking at numbers or percent of expenditures? So it is true that if you're looking at the percent of expenditures, the elderly and disabled populations use up most of the dollars in the Medicaid program. As I was saying before, the expansion population is 700,000 people in the state of Ohio. Kids are about 1.2 million in there, and parents are another 500,000 people in there, and the rest is the age blind and disabled. So does it apply to a small group of people? In Ohio, for instance, it was applying to the 700,000 in the expansion population. And then with all the exceptions, you're down to 36,000, because people are working. People are already working in there. The letter CMS put out about the 1115 waiver, in order to get it approved, they specifically say you cannot expect savings from a community engagement waiver. They say that specifically. If you look at the Ohio application, they specifically call that out as saying that they're not looking at savings in there. The goal is to get people healthier and get people back to work. The idea is if there would be any savings of somebody not engaging, you would take those dollars and reinvest them back into the program.
Do you have any thoughts on that?
One aspect of this policy that is unprecedented is the fact that the waivers that have been approved are entirely restrictions. As you all heard, I have a history with the Medicaid program. I used to run it. And as Jean pointed out, that these types of demonstrations are common. Administration to administration, over the course of decades, these waivers have involved hard choices, but they have been choices that were both expansions and contractions. CMS is explicitly inviting states to cut back their Medicaid coverage. And the waivers that have been approved have done only that with no offsetting expansion. And that is part of the reason that this is extremely problematic policy. In addition, states are spending significant amounts of money to implement this policy. The estimates of the cost of implementation just in Kentucky are about $300 million. This is the bureaucratic infrastructure that the state is creating in order to oversee the work requirements, oversee the exemptions, create the paperwork that people have to fill out. It is not a cost-effective strategy, and it is not an effective strategy for promoting employment.
So Vicki, some of these states will only expand Medicaid, as John mentioned, if they are allowed to include this community engagement component. Isn't a work requirement a better alternative than no access to coverage at all?
I think we should be clear that currently there is no state with a proposal in front of the federal government to expand at all. So this is largely a theoretical argument. And in fact, everything that has been approved so far has been taking away coverage from people who already have it. So there are people in the expansion population who qualify and who may already be working who are losing coverage.
Do you have a response?
Yeah, depending on, it's just how you look at this one, right? As I said earlier, I spoke to the people in Kentucky. They were going to eliminate expansion in Kentucky. The governor ran on that. It was going to go away. They were looking for a way to keep expansion, and this was the way to do it. Again, understanding the different mindsets in different states and how people are looking at it. I grew up in the Midwest. I'm from the Midwest. There's a very strong work ethic there, and it's we don't want to do handouts to people. That's what you're seeing in some of the states. Yes, states already expanded. They expanded under a different governor in Kentucky. So it was, how do you say that? Look at Virginia. I think Virginia was brought up. Virginia's talking about expansion for the first time. North Carolina is another state that's talking about expansion also. But both of those states, in their discussions, the legislature, who has been against expansion, have stated that they would consider it if they could put forward a work requirement.
John, is the federal government's refusal to fund the administrative burden, which is great in some states, as Vicki mentioned, a recognition that the move goes beyond the scope of Medicaid's mission?
So I wouldn't say that it's the federal government saying that. I believe that they're probably looking at the laws and rules that they have in front of them and what they can or can't pay for under those. And then it's up to the state to say, do I want to, as a state, to make an investment to help people get back to work? Again, Kentucky is spending a lot of money on the program. A lot of it is state dollars, but a lot of it is around workforce development, training for people, getting people ready to go back to work and move in those directions. That's one. Every state's different. Ohio had some dollars in that they were asking for specifically around transportation, helping people get back to work. That's one area, though, the federal government said that they wouldn't provide matching funds through the Medicaid program. There's then conversations of how do you take what's out there already, the work programs that are out there already, and work together. I will tell you, having been Medicaid director for 8 years total between DC and Ohio, the federal government programs don't work well together. They work well by themselves. I had a great relationship working with CMS. I never said, I've had a bad relationship, a great working relationship with them. But when you went across the agencies, it was very difficult. When we were putting together a brand new eligibility system to implement the Affordable Care Act, the Medicaid side was relatively easy compared to what's going on now on the SNAP and TANF side and working with Department of Agriculture on that. So I can't say that it's specifically the federal government saying one of those things, but this is back to, it's a state decision. States get to decide, and if they want to say, this is where we will put our money, then they get to make that decision.
Do you have any comments on that?
I think the Medicaid program encompasses enormous state variation. And one of the things that most struck me from my time working with states is how often we were able to come up with state-specific solutions that addressed the state's needs while maintaining the core protections of the program and maintaining the affordability of coverage. We were able to come up with transportation solutions for Alaska, where people have to travel vast different distances, frequently by airplane, to get the healthcare services that people in New York or DC just walk down the street to get. At the same time, we were able to work with Massachusetts, totally different state, to transform their delivery systems to accountable care organizations. There are many different ways that states can meet the needs of their low-income residents. And then there are also states that want to take coverage away from their low-income residents. And I'm afraid that that is the direction that many of these states is heading now.
Both of you have mentioned Kentucky quite a bit. Kentucky has said that the actual number of people who enrolled for coverage in its Medicaid expansion was double the number projected. And while the new jobs created and economic impact from the expansion has been significantly lower than was forecasted, so they're dealing with a lot of financial constraints there. What would be some ways to make Medicaid more financially viable and less costly to taxpayers in those states?
I think if you're looking at the costs in Medicaid, you need to think about exactly what the cost drivers are. The drivers are primarily services to very complex populations like seniors and people with disabilities. Clearly, the cost of prescription drugs is a major driver, and I think that we have a need as a society for better solutions around managing the cost of prescription drugs. I think we can be managing the managed care system more effectively than we are now. And I think that we can be coming up with solutions for very complex and expensive populations that keep them out of the hospital. Again, those are all solutions that work within the existing Medicaid program to help people get the care they need, not take it away from them.
John, do you have any thoughts on those solutions?
Yeah, I do. Well, implemented a whole bunch of them. One of them is value-based purchasing. I don't know if you know it, but many Medicaid programs, if you look at how they reimburse providers, it is straight fee for service. You just get paid, and actually they pay very, very quickly. You have some edits that stop things. You're not paying for what you get. And so Ohio, Tennessee, Arkansas actually put together, under a federal grant, a SIM grant, a State Innovation Model grant, unique ways of paying providers through episodic payment and patient-centered medical homes, where you're incentivizing providers to do better and bring down the cost, and then you share those savings back with them. That is how you bend the cost curve. When I was in the Medicaid director in Ohio, people always say, Medicaid spending is out of control. The Medicaid spending growth in the state of Ohio was over 10% before I got there. In the second budget that I was there, we got growth down to 3.3%. Our definition in Ohio of what was sustainable was to get the program's state share growth lower than what the tax revenues were coming in, right? So if your tax revenues are growing at 4% and your state share is growing at 3.3%, that's sustainable because you actually can pay for the program. But I do want to hit on one thing. We were talking about some of the numbers, and the Medicaid numbers, you have to understand, are actually very large numbers, and people often get lost in that. In Ohio, for instance, when I got there, the program was about almost $19 billion, and we're the 7th largest state. When I left, because of expansion, it was at $24 billion. That wasn't just expansion, we had some other things that went on in there. But when you say it's small dollars for expansion, In the state of Ohio, for those 700,000 people that were added, that's over $3 billion to serve those individuals. So I think in the latest estimates, about 3.8 or $4 billion. That is it for Ohio, and the match that went along with that, that's like $350 to $400 million to cover that population. $400 million is a lot in a budget for the state share of things. And to simply say, oh yeah, states can just come up with those, then money's not there in a lot of states. And that's one of the issues that you're running into. It is a fiscal issue when you're looking at expansion overall.
We want to talk a little bit more about the personal aspect of this. You know, if people have to find work but are from populations that systemically face discrimination, as Vicki outlined earlier, might such requirements like work requirements, volunteer requirements even exacerbate existing health disparities, and how should that be, how can you protect against that?
Yes, they definitely could, and that is, if you look again at the CMS guidance that was put out, they specifically addressed this topic. And I know in Ohio they're specifically addressing this topic too, and that there are exceptions. In all of the waivers that are out there, there's exceptions. And so in the Ohio one, for instance, if it's an area of high unemployment, they can waive the requirements around this. Now there's some question of, I get it on the employment side. People have asked, well, yeah, but what about the volunteer side? Same thing. You can waive those different requirements. Interestingly, in the Ohio model, that's left up to the county level, so those decisions are actually going to be made at the county level of who gets those exceptions. It's not made in Columbus and like this is what it's going to be in the state. So that it has that community engagement in there. So there are ways to design it to help ensure that that doesn't happen. And again, the goal of the Medicaid program for many, many states is not how do we get a person on Medicaid and keep them on Medicaid for a long time. It is in many states, it's we get the person on Medicaid, how can we help them find a job, get off, be healthy to be able to go get that job?
Do you have a response to that, Vicki?
I think the current Medicaid program is doing a really good job of keeping people healthy so that they can find jobs. There is another state Medicaid director who John and I have had to work with, and he tells this story. If he was speaking publicly, and a man came up to him afterwards, and he took out his wallet, and he said, I want to show you something. And he pulled out his old Medicaid card. He hadn't used it in years, but he carried it around with him because Medicaid was there for them when he needed it. He only needed it for a short time, and he hadn't needed it in a long time. But he remembered the role that having Medicaid coverage played for him, and he felt strongly enough about it to walk up to the lead public official in that state and share it. I want to speak just very briefly to the idea of exemptions. Yes, there are exemptions, but I don't think they work because they face two problems. The first is people are going to have to jump through bureaucratic hurdles to claim the exemption. So you can have an exemption for someone who is healthy who unexpectedly gets ill. But is it a reasonable expectation to place the responsibility on someone who has just had a devastating diagnosis to think to raise their hand and go to the state or the county and say, oh, I think I might meet an exemption from this work requirement? I don't think it is. Second, it relies on government officials to make determinations on a person-by-person basis about who is able-bodied, quote-unquote, and who is deserving and who is not. And that's why I worry that the net effect of this policy is not just to affect people, the minority of people on Medicaid who are not yet working for whatever reason. It is also going to remove from coverage people who are working and cannot navigate this new bureaucratic maze.
John, do you have a response to that?
The issue of the bureaucratic maze has come up. And believe me, I have lived through that bureaucratic maze in 2 different states and figuring out how to make it easier to work through. Interesting, and I've said this publicly for a long time, even though being a Republican and being on the right, the ACA did change eligibility requirements and made it much easier to figure out if a person was eligible or not. That freed up a lot of the time for workers in the state of Ohio doing eligibility calculations on an old eligibility system that got the eligibility determination wrong 85% of the time. Okay, 85% of the time they got it wrong, they had to go in and change it. And it was wrong in either direction. So you couldn't just say, oh, every time you flip it. It just was wrong 85% of the time. With the ACA, the new requirements, and the new eligibility definitions, and along with the additional monies to improve eligibility systems, that changed dramatically. So you have a lot of areas right now where things have improved and people are enrolled a lot easier, and you have presumptive eligibility that people can get enrolled very quickly and get services. So there's a lot of those things that are. I also, because I came from a state, I worked in 2 states, I was a consultant in states before that, I believe that the states want to do the right thing, that they do want to try to make people, in general, they usually make an error in the other direction to put people on the program. They want to see people get services. They want to. There's a lot of great state employees, county employees, who are working with these individuals to help them get services. And I have faith in them that they'll make the right decisions. Now, will there always be 1 or 2 wrong decisions? Yes, but that goes on now. Those things happen now. And guess what? Every time those happens, something comes up and you go back and you fix it and you make sure that the person's taken care of. There might be some of those things. But for a couple of those things, I still think, and I still say, that for certain states, you would have no coverage at all.
This may be theoretical, but you had mentioned that this will take coverage away from people. What if it was those folks already enrolled were grandfathered in, but that work eligibility requirement was just given to people looking to enroll with a further expansion? Just getting at the heart of, is it by itself a harmful thing?
That would narrow the impact clearly, but I don't think it makes it significantly less problematic to have people who otherwise qualify for the program not be able to access the health services that they need to get and stay healthy. I think whether you're already enrolled in the program or you're thinking about enrolling in the program, you face the same barriers. Barriers like transportation, barriers like health problems, barriers like childcare or caring for an aging parent. And so, no, I don't think that just grandfathering people in is a sufficient approach. I do want to just speak to the issue that John raised about people trying to do the right thing. Absolutely. State and federal officials try to do the right thing. We're here at a policy school where so many of the students are training to go be public servants and do the right thing. I think that's heartening and terrific. But I think the problem here is that when you erect bureaucratic hurdles, it discourages people from enrolling, and then there are unintended consequences. Washington State, many years ago, made what seemed like a simple paperwork change. They decided to go from having children's coverage renewed every year to every 6 months. It sounds simple, and I'm sure that the people in Washington who implemented the change were good-hearted people. 40,000 children lost coverage. And that is the history of Medicaid eligibility changes. When you make things very difficult for people to navigate, they either lose coverage or they don't enroll.
John, Vicki just mentioned the consequences to changing eligibility requirements. How might a work or community engagement requirement improve the health of Medicaid recipients?
There's been plenty of studies that show that people who have jobs are healthier, that people who are engaged with their community are healthier. In a number of states, there's discussions around for high school kids, in order to graduate, put in a volunteer mandate. I live in one of those communities in Ohio where in order to graduate from high school, you have to do so many volunteer hours, because they know that if a person's more engaged in their community, overall the community's better and healthier. So the idea behind this is there are some people, and as Vicki said and as I've said, and I saw this in Ohio, many, many people on the Medicaid program were already working. We also saw a strong connection between improved health and being employed. You know, in Ohio, we used to do a survey every other year for the Medicaid population. And what we found for the expansion population is that respondents indicated that Medicaid coverage helped them maintain their employment, or if they were unemployed, help them look for employment. So we know that's a positive thing, right? This healthcare coverage is helping them. But despite those encouraging results, there was less than a 2% increase in Group 8 employment rates. And again, what I was talking about, 700,000 people we started with, right? You're down to 36,000 people because a whole bunch of people are already working. What is going on with those 36,000 people? Some of them will have chronic illness. And so how will this help them? They'll be identified. They'll be found. And then the case managers can go out and help them and get services and do some of those different pieces. Some of them probably have mental illness. Some of them probably have substance abuse disorder. Again, if they're found, you can be able to put them into the services and get them the services they need. There was a group of individuals that every time I looked at the Medicaid data and I looked at this, I saw a percentage of people whose income was 0%. And yet, when you looked at any claim that you saw for that person, it was always something like, they went to an urgent care center for a cold or some other minor ailment or something like that. We weren't talking about people getting cancer treatments or things like that. It was minor ailments. When you looked over the time period, they always had 0% income. How could that be? How could they have a 0% income for that period of time? Either A, they were lying to us, or B, it was like there were no jobs in that area, or C, they weren't looking for work and they were just happy to not be working. I don't think it was C. I think it was probably one A or B. And so it's how do you then, again, through the programs that states are talking about, find those people, get them hooked up, and in order to make sure that they can either engage in the community or work.
Do you have a response to that?
Yes, I think in addition to the research that John cited, there was a study in Michigan of their expansion population. 7 out of 10 enrollees in expansion said that having Medicaid coverage helped them perform better at work. And again, this is the issue. Do you have coverage and are you able to work, or are you going to lose coverage? One of the beneficiaries in the Ohio study that John cited said the following, they quoted him or her, give me the freedom to seek a job without having to worry about my health. And that's what we're talking about here, is having the freedom to look for work without having to worry about your heart condition or your back pain, or that that staying home with your children when they're sick is going to have you lose your job and then lose your health coverage. That's what's at stake.
I think many people just want the fairness question answered. Why should some people get health care for free when others, many times low-wage workers, are spending a significant amount of their income on health care?
Well, I think that the problem that your question speaks to is the lack of affordability of coverage for people once their income does exceed the Medicaid income cutoffs, which are really quite low. It is hard to find affordable coverage when you exceed the Medicaid income threshold. And let's be clear, that problem is getting worse rather than better because the Trump administration and Congress have destabilized the marketplaces. So there is an opportunity to provide equity by having more affordable coverage, and some states are moving towards equity by creating Medicaid buy-in programs for people at higher income levels, so that if you are working, you can contribute to the cost of that coverage and also get coverage that actually makes a difference for you and your family.
John, do you have any thoughts on that?
Yes, you hit at the root of the issue in many, many states. Pre-expansion, in both DC and Ohio, where I lived, people supported the Medicaid program. DC was a little bit different. They covered everyone at 200%. They had a state-only or district-only program that covered everyone at 200%. So anyone at 200% was covered. In Ohio, again, it wasn't like that. I had a huge PR problem because prior to expansion, the public supported the Medicaid program because they generally knew somebody on Medicaid. You're like, really? They knew? Yes, because they knew the elderly person who was in the nursing home who was on Medicaid, or they knew their neighbor's son or daughter who had a developmental disability who was on the Medicaid program. And they supported those things, and they were saying, this program is doing well. When we added those 700,000 people, the question that you brought up came up a lot. Why is it I have to work and maintain and pay for my health care coverage when this whole large group of people, and of course they would always say 700,000 people, are getting this for free. I would always push back and say, well, we know 350,000 of those individuals already are working, so they are working, and they are, paying taxes in order to support themselves, in order to, get their Medicaid coverage that they have. So this is a public perception problem. And again, it varies by states, and states are different in one state to another. I gave you the example of DC where this wasn't an issue. In Ohio, again, it was an issue. So how is it that you have the public maintain their support for a program where they're paying for? And again, when I was talking about this, when the headline in the Columbus Dispatch and the Cleveland Plain Dealer and the Cincinnati Enquirer is, the Medicaid expansion is costing the state $400 million, the 11 million people in the state of Ohio start questioning those things. And they start saying, what are we getting for this? What is coming out of this? We, of course, argued we were getting big benefits from it, that we were working to help people get back to work. And we were going to start to fill those 176,000 jobs that are currently available in the state of Ohio. And that's the link that we were trying to get together and get people to understand.
If you'd like to respond.
I
yeah.
would, because I think that the situation that John describes in Ohio is not borne out nationally. 74% of Americans surveyed have a favorable opinion of Medicaid, and it has never been more strong since after the Affordable Care Act. The future of Medicaid was, as you'll recall, extensively debated last year, and it was clear that the program was extremely popular and that people wanted coverage to be maintained, and it remains popular.
Okay, thank you. I think we're going to open up the conversation to all of you. And again, there are two ways to submit questions. You can via Twitter or index card, and I will start sharing those questions now. John, one question is, should rural counties with high unemployment be exempt while urban areas with equally high unemployment are not?
So it says, should one be and one not be?
Yes.
No, they shouldn't be. They should be treated similarly. And just so you kind of understand the dynamics in the state, especially larger states, just because an area is rural does not mean that there's a high unemployment rate. In the northwest corner of Ohio, those counties up there have some of the lowest unemployment rates, or the lowest unemployment rates in the state of Ohio at 2.1%, when the overall unemployment rate in the state is 4.1%. On the other hand, on the eastern side, and the southeastern side in Appalachia, the unemployment rates are much higher. And same thing on inner cities. And all of the discussions that were going on, it's you're looking at a level, whether it be a county level, they were actually looking at it at a zip code level, making the decisions around work requirements on a zip code level or county level to decide with the supply to a person. So no, I don't think they should be treated differently. I think they should be treated the same, just like everyone should be treated the same under the program, looking at the various pieces in there.
Okay, thank you, John. A question for you, Vicki. Can you share with us some instances in American society where individuals did not have to work to gain a social or economic benefit?
I'm not sure I understand the question.
Yeah, I think
entirely.
when I read it slightly differently. Yeah, okay, maybe that wasn't a great one to read.
I'll say,
Yes.
clearly as a society, we value work,
Right.
right? And
I think that was the
it
heart of it.
helps. And working and earning money to support one's family is a good thing and brings many benefits. I think the issue is that there are people who face extremely serious challenges, like lack of transportation, like mental illness, that make it very difficult for them to work and will make it difficult for them to fill out the documentation that's required here.
Okay. Do you have any response to that, or?
Yeah, I think this is the fundamental issue, is that for most people, you get ahead by doing some type of engagement, whether through the community or through work. And I kind of want to hit on the issue Vicki brought up, mental illness. There's exceptions for people who have mental illness. And I want to add to that even before the expansion, for people who had mental illness, and individuals who are intellectually or developmentally disabled. Medicaid has supported employment programs. Medicaid already has in programs, supported employment, that helps those people get back to work. So if you have mental illness, there's a way to be able to work. And again, it's not looking at full-time work, 40 hours. If a person can do that, which I met some of those people in the state of Ohio as we were doing behavioral health redesign, that'd be great. But it's already built in to help those individuals. So to say, oh, it's the end of the world if this happens, I just disagree, because many of the waivers have those things built in. The state's looking at things like, what claims have we paid? I know in Ohio they're simply looking at, do we see a claim paid for mental health service? The answer is yes. The work requirements don't apply to that person. So it's how do you design the program to help people?
Okay, I think, Vicki, you'd like to respond to that.
I think that someone who is experiencing mental illness, perhaps of their first episode, perhaps not, asking them to fill out paperwork and risks significantly setting back their life circumstances. And if they don't do it, they will not get the services that they need to stay well and live in the community. I'd also like to speak to Medicaid's coverage of supported employment for people with disabilities, because it is frequently cited by the federal government as a precedent for this policy. It is not. People with disabilities obtain supported employment services, but they do not lose their coverage if they don't avail themselves of it. Congress in the 1990s explicitly expanded Medicaid eligibility for people with disabilities so that if their income increased, they kept their Medicaid coverage. So the history of Medicaid coverage for people with disabilities runs in exactly the opposite direction of the new CMS policy to force people off of coverage if they do not work.
Okay, John, I have a question. You mentioned not giving handouts. What are the handouts? Are health benefits considered handouts?
In the state of Ohio, when we had these discussions before the legislature, and after we expanded Medicaid, I was lucky enough to have the legislature create the Joint Medicaid Oversight Committee. I got to go before them every month to talk about Medicaid and what great things we were doing, and that was not their view of what I was doing, right? From the legislature, what I got a lot of questions was that specific thing. Why are you giving people who should be able to work, again, view of the world as people 19 to 50 who should be able to work, why are you giving them things for free? We've got work requirements in other programs, right? We were in welfare reform a number of years ago. For SNAP and TANF, there's work requirements there. So they're already looking at it saying, well, we have it over here. Why would we not have it over here? Why not tie those two things together?
It's just an example of the deep ideological divide in this country.
It is, but I think it just doesn't really reflect the real-world circumstances that affect workers and working families in the U.S. I will give you an example, if you'll indulge me. There's another beneficiary in Kentucky, a 47-year-old man, and I want to just tell you a little bit about his life circumstances so you can understand why some of these policies, including voluntarism, that sound good actually don't work for low-income people. He has 2 part-time jobs. He is a mortician and he is a minister, and he also volunteers. He has a number of medical problems: diabetes, high blood pressure, high cholesterol, chronic obstructive pulmonary disease. He has no vision in one eye. He has cataracts and glaucoma, and he is not able to drive. But he works and he volunteers. His income varies between $100 and $1,000 a month. And it varies. What drives the numbers of hours that he can work is the number of funerals that there are, and that he can't predict that. So if he gets to the end of the month and he has not worked the requisite number of hours, he is not going to be able to jump and volunteer to meet the work requirements. And the idea that people like him are going to be able to handle their fluctuating hours that are outside of their control and navigate the bureaucratic maze to maintain their coverage, I think is highly unlikely. And the consequences for someone like him, who has so many multiple conditions, could be severe.
Yeah, that's an argument that you see come up a lot. that low-wage jobs usually are very volatile. And are there enough safeguards in place to, protect folks against losing their coverage?
I think what's hard is we're debating the theoretical on these things, and we don't know what's going to happen. But what I'm talking about is what my work with when I was in the state and coming up and talking about these different ideas. Yes, you can take those differences from month to month, from week to week, and figure out how to do it, right? The question is, for every state, and they are looking at these things. I was just in Arizona the other day, talking to them about another issue, but this issue came up, and they were struggling with this. How do you do this calculation? Ohio is the same question, right? This was one of the questions that was put forward to the state of Ohio. And the state of Ohio, their waiver application said 20 hours a week, or on average 80 hours a month. The question is, how do you do those calculations? Is it actually just 20 hours a week? Because in their waiver, right, they said 20 or an average of 80 a month. So that means it's not 20 a week, so it's 80 a month. Then in addition to that, they specifically have another area in there that says, it's up to the state to decide what the appropriate number of hours is for a person who is attempting to work, who is working and doing some of those different pieces to figure that out. So it's, again, how do you build the program overall and say, this is how we're going to do the calculation? What I've seen in a number of states is they really are looking at it from the standpoint of, we want to keep people in. So if there's going to be a calculation, it's going to be a calculation to help keep people in the program so that you're able to look at those different things. Because remember, what they want to have happen, right, they want to make sure that that person maintains that coverage. That is the opposite of a state that hasn't expanded. I'll give you an example. One Medicaid director in a very large state that has not expanded said, the greatest employment program that was ever created for our state was the Affordable Care Act. The reason was, in order to get health care insurance, your income had to be 100% of the federal poverty level. So guess what they saw? Their unemployment rate went down, or a whole bunch of people who were working less than full-time, or whatever they were at, moved up so they could get on the exchange to get insurance. That's an example of, if you have that incentive, do people adjust to it? And the answer they saw was yes.
A question for you, Vicki. Given that some people will lose coverage, will work requirements shift people into emergency rooms and more expensive sick care and lead to a less healthy population?
The research is clear on the impact of loss of coverage. People have a harder time accessing primary and preventive care and are more likely to wind up in hospital emergency rooms where they will receive more expensive care. And I think that the question raises an important point, that the impact of these policies goes beyond the individuals affected and into the health system overall. Hospitals in states that expanded saw enormous benefits. And if you look at the research on the finances of hospitals in expansion states versus states that did not expand, it is very clear. I think the expansion was probably key to helping some hospitals in rural areas of the country sustain themselves, and that's an important point. But if you are going to depress enrollment in the expansion population, it's going to shift costs back onto hospitals and other providers and potentially raise costs for everyone.
Do you have any response to that, John?
Yes, it depends. It just depends. And you can't say blanketly that it'll automatically drive up the cost. Because again, I was saying, I was looking at the data in Ohio when I was there, and you saw people who were young, and you would see one claim here, one claim there, and they weren't for chronic conditions and diabetes and different pieces like that. What it was people who, relatively healthy, and what we saw was they had some ailment, they went to the ER. Because of the ACA, they were presumptively enrolled into Medicaid. Somebody helped them follow up later on to stay enrolled in Medicaid, and they had it. And they really didn't use it. They went to the doctor and they used it. So there's going to be some of those groups in there. The other individuals, again, there is exceptions for people who are medically frail. That's what the CMS letter says. So, if you're a state, why wouldn't you say that when you found that person who has those chronic conditions or those issues and say, this person's medically frail, we'll enroll them in the Medicaid program, because in that scenario, we may be paying less. Now, one of the other things I do want to hit on is the hospital situation. It is true that hospitals did have a huge benefit because of expansion. That is not something that everyone says is a great thing. Many people say the reason our healthcare costs are so high is that we're overbedded. We have too much inpatient hospital care, and we actually need more care on an outpatient basis, not in a hospital setting where there is an additional facility charge. We need people going to primary care doctors and areas like that. So the fact that hospitals are better off doesn't necessarily help us all. That maybe increase the cost to all of us. In Ohio, we saw this. We saw uncompensated care come down dramatically for hospitals. But what we didn't see is on the commercial side, hospitals lower their rates that they were charging to commercial payers.
So I think we have time for maybe one more question. And this is for John. Research from food stamps and income support programs that have work requirements has not shown long-term effectiveness for connecting and keeping individuals in employment. Why then would it be effective for Medicaid?
I'm not debating whether or not it would be effective or not for Medicaid. As I was saying earlier, a big part of this is, in many states, do you have access to Medicaid or you don't have access to Medicaid? Because the expansion population disappears. The issue is, can you create some incentive to individuals? Again, vast majority don't need this incentive. They're already working, they're already doing these things. Can you create some incentive for those individuals to find a job and maintain a job, or be involved in their community some way, shape, or form to make their community a better place?
Do you have a response to that, Vicki?
I think the research literature from other programs is very clear that these policies create burden and don't increase people's income substantially over time and don't increase their life prospects. When similar requirements were placed in the SNAP program, there were coverage losses that year of between 50 and 85% in some states because these changes can have such serious consequences. So I think the research literature very much supports the ineffectiveness and the burden of these policies. I just want to circle back to the question about hospital capacity, and I think while John is correct that there is excess capacity in some hospitals, I do not think the solution to that is to take away coverage from people. That seems like entirely the wrong tool to solve that problem. That problem, as John well knows, because he ran a really strong program in Ohio, addressing that type of provider issue requires payment reforms. It requires a strong approach to policies at the state level around availability. But I don't think that it is a strong policy argument to say that we should take away coverage for people to reduce capacity in hospitals.
Okay, Vicki, we do actually have a little bit more time. Vicki, another question asking you to elaborate on mental and physical disability aside, why shouldn't someone seek work or be offered work in order to receive a benefit like Medicaid?
I think it's clear if you take a step back and you look at the population that is covered by Medicaid now. Most people work or in working families. A remaining significant share of the population go to school or take care of children or take care of other family members. There is a small part of the population, very small, that is not working. They face significant healthcare needs and significant barriers, and they need Medicaid coverage to overcome them. And taking it away from them, if they do not, is counterproductive. And it will likely jeopardize their health and their ability to work. So again, no one is saying that work is not beneficial. The debate here is about the role of Medicaid coverage in achieving economic opportunity in America. And I think that the research and experience is clear that Medicaid is an engine to propel economic opportunity, and having coverage is an engine to promote it. And I think the opposing side thinks that taking it away from people is what does that, which I obviously disagree with.
And maybe that can go into our, a question for John. Do you believe healthcare is a right or a privilege, and should getting people to work be put ahead of ensuring people get needed healthcare?
I think people should have access to healthcare. And our system in the United States has been set up that way. You have access in various ways, shapes, or form to get healthcare. Now, from there, there's this question of who pays for it? Is it free care? Do you get to go to a hospital for free? How are those things knit together that people can get access to healthcare? The ACA did some great things. Again, in Ohio, it expanded. So obviously, the state of Ohio, when I was there, we looked at it and said, you can benefit. 32 states have looked at this and said, you can benefit from it, and said, we are going to try to improve the health of our population by doing this and moving in that direction, okay? So you got that. You got people saying, this is going to help do that. The question then becomes, what we were talking about earlier, and Vicki hit on a little bit in her last response, and that is, many of the people are working. This doesn't apply to them. Many of the people that brought up as examples and some of the things that they're doing are exceptions already, that these requirements would not apply to them. It's only applying to the people who aren't taking care of kids at home, that they're between the ages of 19 and 50, that they don't have a chronic condition or some other medical frailty. For those individuals, for the rest of us, we generally have to work to get our health care. Why is it different for this population?
Can I just
Yes.
clarify something? The requirements do apply to this population, to the working population, because they are going to have to document that they worked. And that is the concern, or one of the concerns, is that people are going to have, even people who are working, are going to have to go through bureaucratic processes to prove that they are working. And if they don't fill out the paperwork correctly, or they don't do it on time, and in Arkansas, you're only getting 5 days after the end of the month. Or if you don't do it at all, then even if you're working, you're going to lose coverage. And that's why this is the wrong tool to solve this problem. It is affecting working people.
Okay, Vicki, let's move on to your closing remarks now. 3 minutes each, I believe, or 5? 3, yes.
I'll thank everyone again for the opportunity to be there and talk through these issues. And I'll touch back to what I said at the beginning. This approach is harsh, it creates costly red tape, and it is ultimately going to be ineffective. We know that it will be ineffective from a long research literature that shows that cutting people off of coverage for failure to meet similar restrictions had little or no lasting effect on income, and in some cases actually increased poverty. If all states followed suit and made this change, millions of low-income people, including people with disabilities, including children, including parents, would lose coverage. As I said earlier, when similar restrictions were placed in the SNAP program, the enrollment fall-off was significant, up to 85% in some states. And frankly, people with incomes this low should not have to absorb unintended consequences. They can't afford it. But there are better ways. Earlier in the evening, I shared with you some stories of people in Kentucky. I'd like to now share one from Virginia. It is a family that lives in Ashland. They have 2 sons, twins, and when they were born, they had tuberous sclerosis, which is a genetic disorder which grows tumors that cause seizures. So the 2 sons, who are now in their late 20s, are quite disabled. Medicaid paid for a home health aide for one of the sons who is nonverbal and incontinent. The fact that Medicaid paid for that service freed up the parents, and the parents started a small business. They create parts that go into semiconductors and medical devices. It also paid for supported employment and job coaching for the second son, who was less profoundly disabled. He now works in his parents' business, and he earns enough income to pay taxes. This is the way that Medicaid delivers on the promise of economic opportunity for low-income Americans. And this is the way, maintaining this coverage and ideally expanding these types of services to more people, is the way to help people move up the economic ladder. It needs to provide job training, we need to address childcare, we need to address transportation. We do not need to take Medicaid coverage away from people to get them to work. And in fact, maintaining Medicaid coverage for everyone who qualifies is a key part of the solution. Thank you all for having me this evening.
Thank you, Vicki. All right, let's hold applause to the end. John, you can give your closing statement.
So when did work become a four-letter word? Right? When did work become this bad thing that if somebody was working, this was terrible? One of the things that Vicki hit on there was somebody who is already working, they're going to be disenrolled. They're going to miss a deadline. There's systems that can be put into place to do that. There's all kinds of backups. You can give people an extra month. There's all different ways to implement this so that it doesn't have those negative consequences. And it is 2018. There's lots of ways to report this data now that was not available previously. You can look at tax data that's coming in. We have new eligibility systems that are actually doing eligibility on the fly with all new databases. So I believe that there's all types of technological ways to overcome those different things. What I also want to say is this. The debate isn't, is this going to be a nationwide enforcement across all states? It's left up to the states to decide. States are deciding. Each one gets to do it. And these are done through 1115 waivers. And studies have been talked about around, this study's proved this and this study's proved that. They have, I'm not disagreeing with those, but what they haven't applied to is this specific area and the different ways that states are going to do them. That is what 1115 waivers are for, to experiment to see if things can be done better and people can be made healthier. That's what we want to figure out. How is it that when we've added so many people to the Medicaid program, how can we ensure that the program is around for the future populations? So the program is around for the people who need it. That's what we're looking to try to do. Thank you.
Thank you, John. So now is the moment of reckoning. You all get to vote again, and you're familiar with it. We're going to put the instructions on the screen there. And so we'd like you guys to vote again on whether people who can should work for their Medicaid. Oh, before it was 27 said yes, 27%, and 60% said no, and 13% were undecided. So let's see if any minds were changed tonight. Oh. Oh, wait a second. Okay. We have to wait. We have to be a bit patient with this.
Looks like it's hot.
Some minds were, let me not speak too soon. It seems like for sure there are fewer undecided. So that's a good thing. Okay, I think we've got the final tally here. For yes, it's 32%, and that's up from 27%. And for no, it's 64%, up from 60%. So thank you all. Not a huge difference, but thank you all for voting. And let's thank our speakers once again for sharing their viewpoints. Thank you all. Thank you all. Have a nice night.